This susceptibility profile for Proteus mirabilis describes a multi-drug resistant isolate with a phenotype highly suggestive of an extended-spectrum beta-lactamase producer. The isolate demonstrates high-level resistance to ampicillin, aztreonam, and nearly all cephalosporin generations, including cefazolin, ceftriaxone, ceftazidime, and even the fourth-generation cefepime. Furthermore, the isolate displays co-resistance to fluoroquinolones, aminoglycosides, and trimethoprim sulfamethoxazole, which is common in ESBL-carrying plasmids. Therapeutic options remain limited to carbapenems, such as meropenem and ertapenem, the cefamycin cefoxitin, and the beta-lactamase inhibitor combination piperacillin tazobactam. Regarding the excluded antibiotics, tetracyclines are not tested because all Proteus species are intrinsically resistant to this class due to a chromosomally encoded efflux pump. Therefore, testing would provide no clinical utility. Imipenem is often omitted or replaced by meropenem in Proteus panels because Proteus species frequently exhibit naturally elevated MICs to imipenem specifically. This is not due to a resistance enzyme, but rather a combination of lower porin expression and reduced binding affinity for the drug, making meropenem a more reliable indicator of true carbapenem susceptibility for this genus. The susceptibility profile of this Proteus mirabilis isolate is a significant example of acquired multi-drug resistance. By examining the MIC values, we see a clear pattern of resistance across almost the entire beta-lactam spectrum. The high MICs for ceftriaxone and ceftazidime, combined with resistance to the fourth-generation cephalosporin cefepime, strongly point toward the presence of an extended-spectrum beta-lactamase. Interestingly, the isolate remains susceptible to cefoxitin, acefamycin, and piperacillin tazobactam, which is often observed in certain ESBL phenotypes before further resistance mechanisms like AMP-C or carbapenemases are acquired. Beyond the beta-lactams, we see extensive co-resistance. The fluoroquinolones, ciprofloxacin and levofloxacin, show elevated MICs, as do the aminoglycosides gentamicin and tobramycin. This clustering of resistance is frequently the result of multiple resistance genes being carried on a single large plasmid, which is then horizontally transferred between bacteria. When we look for therapeutic windows, the carbapenems, meropenem, and ertapenem remain highly effective with very low MICs, indicating they have not yet been compromised by carbapenemase production. You may notice that certain drugs like tetracycline and imipenem are missing from this analysis. This is a deliberate choice based on the intrinsic biology of the Proteus genus. All Proteus species possess a chromosomal efflux pump that renders them naturally resistant to tetracyclines, making testing redundant. As for imipenem, Proteus often shows naturally higher MICs compared to other Enterobacterales, due to specific porin and PBP configurations. Because these elevated MICs can lead to false resistant interpretations in the absence of a true carbapenemase, laboratories frequently prioritize meropenem as the more accurate clinical marker for carbapenem efficacy in these isolates. Understanding these genus-specific nuances is critical for accurate antibiogram interpretation.